Hello, everybody. My name is Steve Drzewoszewski, and first and foremost, I would just like to thank you for lending me a little bit of your time today and to listen to what I have to say. Just to give you a little bit of background on me, I've been in the field of substance abuse treatment for 16 years. I graduated University of Southern California for social work. I am a licensed clinical alcohol and drug counselor, licensed clinical social worker, a certified clinical supervisor, and a member of MINT, Motivational Interviewing Network trainers. All that really means is I'm just a nerd. So just to put that out there for you right away, I hope you enjoy the presentation. So let's just get right into it. All right, so we're going to talk about motivational interviewing. We're going to talk about the opioid epidemic. We're going to talk about driving factors today, what drives opioid addiction and what it means to recover. And we're going to talk about evoking change. How do we play a part in our patients' recovery and not get in the way? Because sometimes we can get in the way as well. So how do we do that? My objectives or goals for you today would be for you to walk out of here with a basic understanding of the opioid epidemic, develop some insight into the driving factors of opioid use disorder and what it means to recover. I think I said that already, but I'll be redundant. And an understanding of motivational interviewing and what it means to use that to evoke change in opioid patients. It doesn't have to just be opioid patients, but that's what we're talking about today. But it is transferable. It's a transferable skill. So, okay. So the opioid epidemic, I want to start there because I think it's important to understand that there are three things that actually are drivers, and there's probably more, but the three that I kind of most cue into when I look at the opioid epidemic are three things. One of them dates all the way back to 1980, an article that appeared in the New England Journal of Medicine called "Addiction Rare in Patients Treated with Narcotics." We know that's not true, right? So, but in 1980, think about what it was in 1980, what they knew, what they didn't know. They were doing studies. They were trying to figure things out. It's unclear as to how much we actually did know at that point, but they did a study and they concluded from that study in this article that despite widespread use of narcotics in hospitals, the development of addiction is rare in medical patients with no history of addiction. Now, this was written by Jane Porter and Dr. Herschel Jick. Dr. Herschel Jick later actually stated that he regretted writing this article because it basically gave some precedent to what was going to happen next, which is the overly aggressive pharmaceutical industry pushing narcotics, which we all know they do, and they did. And some of them have actually gotten a lot of trouble. We know about Purdue Pharma with the OxyContin, scandal, which there's been several lawsuits and legal charges and legal proceedings, with some research that they had done that was not 100% accurate or misrepresented. But we know that the pharmaceutical company can be pretty pushy when it comes to pushing some of this stuff. And sometimes if there's an unfavorable result in some of the research, especially related to addiction, with the OxyContin situation, that was certainly the case. And we know it is highly addictive, and it was initially pushed out there as it wasn't very addictive. It was much less likely to be addictive than other pharmaceuticals or narcotics. Then comes the fifth vital sign. That was something that came about in 1996. It was a big campaign, a big push by the Pain Society, American Pain Society, and then later adopted by the Joint Commission in their pain management standards in 2001. And it lasted all the way until April 2016. Which is when they started to roll it back and realized that this may be a mistake. They reevaluated a lot of data. And, unfortunately, by that point, the bell had been rung. Way too much has gone on. I'm not saying, it was, you can't do anything about it. But there was a lot of damage already done at that point. Then we get into some overdose statistics just for your knowledge. since 1999, opioid overdoses have quadrupled. We know that. The majority of overdose deaths are, 6 out of 10 are related to opioids or opiates, either one. From 2000 to 2015, 500,000 people died from opioid overdoses. Actually, just overdoses, but we could just do the math. 6 out of 10, it's probably a good majority. And 91 Americans die every day from opioid overdoses. And lastly, unfortunately, these are very grim numbers. I hate putting them out there, but it is the reality. All right, so here's just some rates of admissions for opioid use disorder in the United States. And we're going to go through a few years real quick. And now this is 45 people or more per 100,000. So I'm just giving you that when you get into the red, like that really deep red number or that red color. So just giving you that. And you'll see how it kind of spreads. Here's 2001. So you can see how it's getting into 19 to 44 per 100,000. There's a few states there with the deep red, which is 45 or more per 100,000. And then it just goes to 2003, 2005, 2007. Now, remember those 3 factors that I brought up. This is the contributor. You can see it kind of matches up with the years. This is like right in the middle of, as we go through here. This is actually 2009 is like right in the middle of the 5th vital sign situation in conjunction with the overly aggressive pharmaceutical company, armed with the article written in 1980 by Herschel Chick. So we have this whole thing, kind of a perfect storm. All right, so some of the signs of opioid addiction, physical signs are appetite. Someone's appetite drastically changes. Bloodshot eyes or pinpoint pupils. That's kind of the pinpoint pupils is the real dead giveaway. If they're not responsive to light, changing, they're not going, they're not moving, they're just kind of pinpointed. That's a very good indicator that someone might be on opioids. Just so you know, if someone's on stimulants, it goes the other way. They dilate, they get really big, and they don't change. So impaired coordination, slurred speech, runny nose, sleep changes, abnormally dressed for the weather. Some people are like, why is that? Because what happens is, you might see someone who's high on their drugs wearing a short sleeve shirt in the middle of winter, running around outside, or no jacket. Or you might see somebody who is going through withdrawal, overly dressed for a hot day because their bodies, they're getting chills. Their body doesn't feel well. Psychological signs and symptoms, anxiety, euphoria. There's a whole bunch of different things, nervousness, rage, anger. I mean, all these things can be triggered by, depending on what's happening with the addict at that time. They could be happy as they can be while they're high. And then when they're not high, their whole focus, remember that lower level of the brain is in control. So you got emotion and, that flight freeze response kind of taken over. They can have some serious outbursts and do some pretty awful things in order to get their drugs. And I'll say this as well. Drug addicts are not bad people trying to get good. They're sick people trying to get well. This is just how the disease manifests. We need to break the stigma. This is not something that anybody sets out to do. This is not something that anybody says, what I want to be when I grow up? I want to be a drug addict and steal from people I love and do all that stuff. They don't do that. Unfortunately, the brain gets hijacked, and this is kind of how it manifests. All right, going forward, we get into what does the treatment model historically look like for substance abuse? Well, I could tell you, it used to be you'd walk into an addiction counselor's office and you would say, people around me say I'm a drug addict or I'm an alcoholic or whatever the case is. And they would say, okay, well, what do you think? Well, you would say, no, I'm not. They got the problem, not me. And the counselor would say, well, come back when you're ready, right? Come back when you're ready to make a change. If you're not willing to go there, or especially programs, if you're not ready to admit it, Or if you're not ready to accept what you need to do, then you're not ready. Come back when you are. Well, that's a terrible way of doing things. My perspective is it's our job to get them ready. All right. If someone comes in and they says, I always share this story. I had a drug addict, or I'm sorry, this is an alcoholic, but it could be, like I said, all this is transferable. She came in, she got caught drinking on the job. She came into my office one day when I was running an outpatient program and sat down in a chair, crossed her arms. You can always tell when people are very defensive. They cross their arms a lot. She crossed her arms and she sat down and she said, I'm only here because I got caught drinking at work. I'm not an alcoholic. I don't believe it for a second. We were just having fun that day and I was drinking and it was a snow day. It was snowing outside. So we were just drinking. And there's nothing you could say or do that's going to make me think I'm an addict or an alcoholic. And I said, okay, well, why are you here? She said, well, my job is making me come here. I said, all right, well, since you have to be here, and this is where I started it, since you have to be here, and some people think I'm pretty easy to talk to, what do you want to talk about or what do you want to work on while you're here? Why don't we start somewhere? Let's talk about, the job and how you're, what your experience is with your job right now. We went in, and she ended up staying in the program for the full time. And by the time we were done, and it doesn't always work out this way, but she's still sober today and is, actively involved in AA, which is one way to do it. And is doing very well as far as I know. I haven't talked to her in a little while, but last I heard she's still doing well. So that's just a good story with someone who might have been turned away, going back to where we get into the historic models. It was based on deficit. It was based on looking at, what are your problems instead of strength-based programming. The therapist was the one-up position. I'm the expert. You're the addict. Listen to me. I know what's best for you. That's terrible. I always say, be careful of the expert trap. You don't want to be there. It was very much based in confrontation. It was one size fits all. Here's our program. If you can't do it, well, then you got to go. We don't do that today. Anyone who is still doing that, you got to really look at what you're doing because it's not helping. Expected people to be ready to change when they first came in. I talked about that. It's our job to get them ready. Most people are not ready to change when they walk in your office or come in, for opioid treatment or even dealing with it in the ERs or anywhere else. I mean, they're usually not ready. So you got to figure out how you're going to get them ready. It was also full of judgment. You're the addict. It's part of what kept the stigma going and still keeps the stigma going to some degree. Overly directive and focused primarily on psychoeducation. So it was basically, we're going to give you a bunch of information. We're going to tell you what to do. You have no say in the matter. This is it. If you don't do this, you're probably going to relapse and it's just going to be terrible. So don't even come back. Right. So that's kind of where addiction treatment used to be, unfortunately. Now, that being said, a lot of people still got better. Don't get me wrong. Some of this works. Sometimes this stuff works for some people, but you got to know who it's going to work for. You can't just do it blanket across the board for everybody. So I'm going to give you a gift. Motivational interviewing. We're going to talk a bit about that now. Since I spent a lot of time talking about other things, we're going to talk about this. Motivational interviewing. What is motivational interviewing? Well, here's just one statement that I think covers it all. People are the undisputed experts on themselves. No one has been with them longer or knows them better than they do themselves. In MI, the person who's working with them, the counselor, the therapist, the nurse, whoever, it takes on the role as the helper. All right. They're the companion who typically talks less than half of as much as the client does. You let them talk, right? And there's ways to do that. There's techniques that we use to make sure that we're allowing them the room they need to self-explore, because this is not something I'm not going to get sober for you. You have to get sober for yourself. So why am I doing all the work? Why am I the one, directing it? I may tell someone to do something they have no intention to do. Well, I need to find out what they're willing to do. Right. So that's it. And they know what they know a lot of things. We're not going to browbeat them into recovery. they know for themselves, which is where that statement comes. They know themselves better than we do. Really important thing to keep in mind. All right, 10 things MI is not. Motivational interviewing is not the trans-theoretical model, which is the stages of change. I've had people actually say, yeah, I do MI all the time. We talk about the stages of change. No, that's not the stage. That's not motivational interviewing. The best description of that is they're kissing cousins never married, right? So the stages of change are kind of a tool you can use with MI, but it's not a necessity. It's not a way of tricking people into doing what you want them to do. It's not a technique. It's not decisional balance, which is another tool you can use in MI, but it's not that entirely. It's not assessment feedback. It's not cognitive behavioral therapy. It's not client-centered therapy. It is not easy to learn. It is not practice as usual. It is not a panacea, a cure-all for anything. It is not that. So we have to remember that, this is not the answer. It is just something you can do with a client. More things it is not. It is not an intervention. It is not something you do to a client or on a client. I always say it's something you do for a client, right? It's something you do for them, with them, but it's not something you do to them or on them. MI is not something you do instead of what you do. It's something you like. This is a big question that comes up. Do I do cognitive behavioral therapy? I have people who ask me that. Do I practice cognitive behavioral therapy at all? I absolutely do, but I do it in the spirit of motivational interviewing, right? So you can do motivational interviewing has a spirit side and kind of like the practice side. I do everything with the spirit of MI, which is what? Giving patients unconditional positive regard, trying to see things from their side of it. I mean, I'm going to go into all that in a second, but this is where you get into the MI, the nitty gritty, right? It's not something you do instead of what you do. It's something you just kind of build into what you do or as a piece of what you do, right? So, definition of MI is it's a counseling approach developed in part by clinical psychologist Bill Miller and Stephen Rolnick. MI is a goal-oriented, client-centered counseling style for eliciting behavioral change and helping clients explore and resolve ambivalence, right? That's really important. That's probably my favorite definition of MI all the way around. It's a way of resolving ambivalence. When people ask me what I do, I've worked in detox, rehab, outpatient programs. People often ask me what I do, and I say I resolve ambivalence. We should meet each client with an intellectual curiosity about his or her perspective, understanding, and motivation, right? So what does that mean? That means we should get the client's input. Don't just tell them what to do, what we think they should do. I always say never give advice unless you ask permission first. I always, I will listen to them. I will reflect back what they're saying a lot to get them to explore it some more. But I will certainly never give advice and be directive without saying, hey, could I give you some of my thoughts on this? And, at that point, they a lot of times they say yes. Sometimes they might say no. I don't know. But, for the most part, they're pretty okay with that. And you always do better if you ask permission first. So the 4 processes of MI are engage, focus, plan, and evoke, right? So we want to engage the client in the conversation. We want to build a rapport with the client. We want to get, at least that conversation going, them to get interested in the conversation. Then we want to make sure that it's focused. We want to know what are we trying to do, right? We want to see, let's put it this way. If you're working with someone on, let's say, nicotine addiction, the goal is obviously to stop smoking, right? So let's focus it down on that. Of course, with opioids, it's going to be, we want to quit opioids because eventually it's going to hurt you or kill you. So we want to focus on that. That is the goal, right? To quit. However, they may not be willing or ready at that time. We have to accept that as well. We have to have a plan, right? You develop a plan. This is just not, MI is just not an endless conversation of reflecting and open-ended questions and gathering information. We need to have a plan. And then eventually you need to get to the evoke that change talk, right? Where does that change talk come from? There's two types of talk that we really focus in on in MI. It's sustained talk and change talk. Sustained talk is, the status quo, preserving the status quo, right? What would an example of change talk be? I might say, have you ever tried, quitting before? Have you ever, tell me about a time when you might have tried to stop? And they'll say, well, I don't really want to try to stop right now because, I don't, it's too hard, it's too hard. And that's what we call sustained talk, right? So looking at it from a therapeutic perspective, and what I would do at that point is, change talk. If I go into change talk would look like, well, yeah, it sounds like you really got to stop. Well, what happens there? Well, the client goes back the other way. The client backs away from that because that's not what they want to hear, right? But sustained talk, I might reflect back that sustained talk, right? So yeah, I might say, they might say I've tried before. It's so hard. I don't think I want to try now. Or it's just too hard for me to try to stop. I would say, it is difficult. It's a tough thing to do to quit. I'm not asking, if it's, asking you to do something easy here. It's a tough thing to do. And then they will start to talk about that. They'll say, yeah, it is tough. And then you have a conversation going. So you basically steered into the sustained talk. Of course, there's times you're not going to do that. If they have a dangerous idea, you're not going to go into sustained talk, obviously, on that. But, it's something that's very useful. I use it all the time. I work with clients all the time with sustained talk and steer right into that ambivalence. And it tends to gear them towards making change because you want it to come from them. Me telling them they need to change is not going to do any good. Them understanding they need to change is a much better way to go. So MI, how do we do that? We use open-ended questions a lot. What is an open-ended question? I mean, I could take anything pretty much and make it an open-ended question. Tell me a bit about what's going on in your life right now. How's your relationships with your family? Those are all open-ended questions. Affirmations, I think you should use them often. Tell them what they're doing well. Make sure that they understand that they're doing certain things well. Reflective listening, like I did before, client comes in and says, I don't feel like stopping. I don't think I can. Well, yeah, stopping is tough. I hear you. I get that. It's a hard thing to do. And then you just stop it right there and they'll continue. That's how it works. Summary, which is basically just a long reflection. So that's kind of like a capstone. So when you start to get to the end of that particular part of your conversation, you're going to, summarize what you think you heard. The good thing about summaries is if you got a misunderstanding of what they're trying to tell you, same thing with reflections, they will just, correct you. People say to me all the time, what if I get it wrong? Well, then they're just going to tell you got it wrong. And then you're going to be like, okay, I'm sorry, I misunderstood. Let's, so where do we go from here? Right. You figure that out. These are all basic interactions, techniques, skills that you use early and often with clients in the motivational interviewing approach. This is important. Express and show empathy towards clients. What is empathy? Empathy is, trying to understand where they're at from their perspective. Like I said earlier, how do we do that? I actually, this first one I kind of took from a friend of mine, a guy named Stephen Andrew. Love this thought is listen to a client with warm ears, soft eyes, and an open heart. All right. Really important. What does that mean? That means kind of just be there sometimes with the client, just be with them. Listen to them. Sometimes a soft eye is kind of just looking a little off, not directly gauging right into somebody, because sometimes that could be a little, daunting for them when you're kind of sitting there concentrating really hard and looking right at them. But, just steer off a little bit sometimes. Always have an open heart. They're going through stuff and it's important to understand that. And just being with them sometimes is all you need to do. Clients don't care about what you know. I learned this a long time ago. I have a lot of letters. Clients don't care about that. Clients don't care how wicked smart I am. Clients care about how much I care about them. That's it. Clients care how much I care. So they don't care how much you know, they care how much you care. I can't say that enough. Did I say it enough? I'll say it one more time. Clients don't care how much you know, they care how much you care. I think that's true for most people, to be honest with you. I mean, I could walk around and say, I got this letter, that letter, and this letter, and they don't care about that. What are you going to do for me? How are you going to help me? Do not judge anyone ever. All right. Don't judge. Judgment is someone once said judgment is the ultimate form of violence. I don't know if I agree with that or not, but it certainly doesn't feel good. Judgment is not something any of us enjoy. Nobody wants to be judged. Of course, it's something we do sometimes automatically. We don't, we've all had clients maybe we don't like, right? And that's sometimes hard to get past, and we have to understand. I think the biggest thing we need to do is be able to self-reflect back. What is my problem here? Not what's the client's problem, what's my problem, and start to work on that and figure that out. And if you have to, you tap out, you get somebody else to work with that client. But don't judge. Resist the righting reflex. What does that mean? Automatically, we always want to fix things, right? Don't we? I mean, that's why people get into this field of healthcare. You get into the field of counseling, you get into the field of working with clients. We want to help them get better, right? Well, sometimes, you don't have the right words anyway. So you just got to let things be where they are. Client says something that's very difficult for them, or maybe they start to break down into tears. First thing most people do is hand them a tissue. Well, what does that mean? That means, I'm uncomfortable with your crying, so please stop. That's the subliminal message you send when you hand somebody a tissue. You think you're being nice, but the subliminal message is, you're making me uncomfortable. Here, have a tissue, and please stop that. I always have tissues in my office. I have them on my desk. I do not ever give them to anyone. It's not that I'm mean. If you want one, you'll take one. If you don't want one, I'm not going to hand it to you, because I'm okay if you need to do this right now. I'm okay with you needing a moment, because sometimes that's what we need. Also, people will tell us their problems and automatically want to go in there and we say, it's going to be okay. We're going to help you fix this. Well, it may not be. So resist the righting reflex. Let people go through. How do you get through ambivalence, right? Ambivalence is, I want this and I want this at the same time. Well, I always say, when you get into ambivalence, it's kind of like if you say to yourself, I'm going to this picnic and I'm going to eat healthy. I'm going to go out, I'm going to eat healthy today. And what I'm going to do is I'm going to eat the salad today. I'm not going to eat anything else. And you go to the picnic and you find this salad and you're like, okay, that's what I'm going to eat. Then they bring out the chocolate cake and you're like, now you're in ambivalence, right? Now you're like, oh, that looks good. I know I should do this, but I really want that chocolate cake. That's ambivalence, right? So, and sometimes we need to be uncomfortable to go through that, right? To get through ambivalence, you need to be uncomfortable. How do people change? They become uncomfortable with their old way of thinking, right? They become uncomfortable with the way things are going for them. So they need to make a change. But if we can actually get in the way by trying to fix it. So we got to make sure we stay out of the way, let them go through some of the things that they need to go through. Understanding clients' own motivations, listen with empathy, obviously, and empower the client, right? We want to empower people. You can make a change. You can get better. What do you bring into a session, or what do you bring into a communication? What do you bring into a moment with somebody, right? Ego is the enemy of good therapy. I often say that. I actually have an ego box on my door, on my office door. Everybody checks their ego at the door because it doesn't belong in therapy. This is not about you. This is about the client. And you got to take yourself out of it. Anytime you're dealing with an addiction patient, an opioid patient, take yourself out of the equation. Really important. And I'm going to leave you with the violin. The reason I put the violin up is because I want you to understand that motivational interviewing, this is just a very basic description of some of the things that we do in MI. But, how long do you think it would take you to learn how to play a violin? 10 years? 20 years? I don't know. But I know it wouldn't be in a day. And I know it wouldn't be in one presentation from Steve. So I don't know how to play the violin, by the way. I don't know that I'd have the time and energy to put into playing the violin, but I put that there just because I want you to understand that if you want to learn motivational interviewing, I know a lot of nurses, doctors, all kinds of people that utilize MI. You could certainly reach out to me. I could direct you into how to learn some of the skills involved in MI, or hook you up with some people that can train you. Please let me know if you are interested, but it is a journey. It is not something you learn. I've been doing MI for probably 12 or 13 years, give or take. And I still find myself messing it up sometimes. So, but that's part of it. It's going to take you a while to learn the skills, if you want to. If you don't want to, that's fine, but at least understand what it is and understand the spirit of it. And, no matter whether you're going to do MI or not, I guess the key takeaways when you're dealing with opioid clients from my presentation are: don't judge, listen with empathy, try to understand where they're coming from, and always ask permission to give advice, because sometimes advice without permission sounds like judgment. So just remember that. And that's pretty much what I have. Once again, Steve Drzewoszewski, have a wonderful day and hope you enjoyed the presentation.